Hello everyone, you are watching sqadia.com and I am Dr. Hamad Haider. Today we'll be discussing the two very important pediatric conditions. One is the hip dysplasias or developmental dysplasia of the hip joint and the transient synovitis. Then first we'll be assessing what is briefly the developmental dysplasia of the hip joint. We'll be discussing what is a normal hip joint and how actually the acetabular dysplasia affects the growth and eventually leads to some form of a developmental dysplasia of the hip joint. Then we will be coming on to some form of a classification of DDH, and we will be briefly discussing what are the different ways to classify DDH and why we have to develop this classification, because it's not purely a congenital disorder. It's not CDH, it's DDH. Or as the child develops, the problems also develops along with it. Then we'll be discussing the two very important clinical tests. One is the Barlow and other is the Ortolani. We'll be discussing that in detail, that how to perform an Barlow test and Ortolani test along with the Galeazzi test, and what are the different risk factors you have, and when to have highest index of suspicion for the child to have a DDH. From then we'll be moving on to how to perform the Ortolani test and what is its significance, and what is actually the dislocatable hip and what is reducible hip. From then onwards we will moving on towards what are the different form of treatments, whether it is Pavlik harness and in which age bracket we can go for Pavlik harness. Then from 6 months to 18 months, what is the treatment option we have usually is the closed reduction, internal fixation. We'll be discussing in detail what are the steps to go for how to reduce the head first, what are the different steps to go for operative arthrography, and how to do the closed reduction and then apply the spike as well. From then we'll moving on to some form of open reduction techniques and osteotomies as well. Usually after the age of 5 or 6 we may have to go for some form of a acetabular or pelvic osteotomy, which is the most commonly done is the Salter osteotomy along with the femoral osteotomy, which may include varus derotation or femoral shortening osteotomy. We'll be also discussing another form of acetabular osteotomy such as Pemberton or periacetabular Ganza osteotomy. We will be briefly discussing what the indications for Salter, Pemberton and periacetabular Ganza osteotomy as well. From then we will be switching on to the next important topic around the hip in the pediatric population is transient synovitis, which mimics multiple other problems such as inflammatory arthritis or septic arthritis. And we have to go for the detailed history and examination to rule out whether the patient may have septic arthritis or proximal femoral osteomyelitis. That may be associated with leg calf palsy disease or multiple epiphyseal dysplasia as well. And if a child is around 10 to 12 years or 13 years of age, then the patient may have to have a SCFE as well, especially if a child with transient synovitis of the hip joint of 13 years of age comes with a knee pain, you must rule out SCFE along with that as well. From then onwards, we will moving on towards the treatment of the transient synovitis. Most important to know is that there is no surgical treatment. The most commonly the treatment is symptomatic and conservative. First and foremost is bed rest, that you ask the patient to continue rest, put the limb in the most comfortable position along with the use of non-steroidal anti-inflammatory medicines, whether in form of oral medication or IV as well, along with the use of crutches to actually give the limb support. And with over passage of time, usually the synovial effusion resolves and patient becomes normal. If you want to watch this complete lecture, go to www.sqadia.com and watch these two topics over there. And if you want to watch any other lecture related to orthopedics, you can go to the same site and watch all those lectures over there. Thank you very much. Keep watching sqadia.com.